outcomes. Therapeutic, psychosocial, and policy level interventions to improve cognitive and mental health outcomes in infants, children, and adolescents affected these exposures. So welcome Dr. Sarah, and karibu sana to the symposium. So we will now give you an opportunity to talk.
Thank you so much. It's really just a huge pleasure and honor to be here to speak with you today. I'll just take a second and share my screen. Hopefully everybody can see that. All right, I see a heart, so I'll take that as a good sign. So again, thank you so much for the invitation to talk today. I'm very, very excited to share a little bit about the research that I've been doing in collaboration with Sarah Degwa, who is my co-presenter today. And I'm going to talk about some novel methods for hearing screening that we've been researching together here in Kenya. And I will see if I can just advance my first slide. So I'm going to talk a little bit about just really the importance of hearing in brain development, and I will also highlight some of the challenges and opportunities in early hearing detection that we are thinking about as a research team. And I'll talk to you about two novel tools to assess hearing and ear health that we're interested in evaluating more broadly. And I'll also highlight a couple of research directions that we're interested in. So if you were on this webinar yesterday, you would have heard Dr. Catherine Wedderburn introduce a really important point, which is that brain development is both dependent on experience, and it's also occurs in a sequential order. And one of the important capacities that develops extremely early in life is sensory capacities, including hearing. And hearing is especially important for later development of language skills, and on language skills, other skills are scaffolded. So all of this is very important for development of higher order cognitive and social skills and many, many aspects of child development. And so hearing capacity is really tightly and inextricably linked to far-reaching outcomes that are important for children, including their ability to communicate and their capacity for language and speech, their cognitive outcomes, how they do in school, their prospects for employment, and their social-emotional well-being and their connection to community. So hearing is incredibly important, and hopefully one take-home message that you'll come away with today is just the understanding of how critical it is to address the fact that WHO estimates that 35 million children in the world have moderate to severe hearing loss. And because of the far-reaching impacts of hearing, it's important to identify these children as early as possible in life. Now, 60% of hearing loss is actually tied to preventable conditions. And one thing that you'll notice from the infographic that I've put on this slide is that many of the conditions that contribute to hearing loss are also very important early life conditions. So genetic factors can play a role, as well as certain adverse birth outcomes, including hypoxia, low birth weight, and preterm birth. And then also, there are certain perinatal morbidities and maternal exposures to infectious diseases that can be very important for increasing the risk of hearing loss. And so one aspect of thinking about hearing capacity is that it's very important to try to identify hearing loss early in life. The WHO, as well as the Kenyan Ministry of Health, recommends the 136 guidelines. So those are easy guidelines to remember. And the way that this works is that the guidelines basically say that by 1 month of age, all babies should have their hearing screened. And by 3 months of age, all babies who screen as potentially having hearing loss should have access to diagnostic evaluation. And then by 6 months of age, those who are identified to have a hearing loss should have be placed in early childhood development support and other recommended follow-up care. And this slide illustrates some important successes and some gaps in these in the availability of these of services in line with these guidelines. So, for example, this infographic shows data representing uptake and access to the 136 guidelines in Washington State, which is where I live. And what we see here is that although there's a huge success, which is that 95% of babies in Washington State have their hearing screened by 1 month of age, there's still a gap. 60% of those babies who screen positive are actually diagnosed, and then only 50% receive the requisite follow-up care by 6 months of age. But one big success that you can also hopefully appreciate from this picture is that, for example, for a child who is diagnosed at a very early age and receives this important follow-up care, placement in a mainstream school setting is entirely possible. So this child here is deaf and was diagnosed by 3 months of age and is in mainstream school by 3 years of age. Now, there was a very important study conducted here in Kenya led by Professor Isaac Macharia. And what this paper really highlights is the fact that, in Kenya, there's a very different picture. So what this research team did was conduct a population-based survey of school-going children and assessed their hearing using pure tone audiometry. And this study actually evaluated hearing in nearly 1,500 children at a mean age of 8.5 years. These researchers identified 35 children with hearing loss and then talked to 33 parents about their experience. And what they learned was that nearly 70% of these parents who were interviewed were already aware of their child's hearing loss, and that the mean age at which they recognized that there was an issue with their child's hearing was at about 5 years. And then just under 30% had sought some sort of assessment for this hearing loss, and just 3% were actually referred for screening, and none of these children had hearing aids. And so what I think this study really speaks to is that both parents and providers really lack the resources that they need to address the needs of these children. And this slide also highlights, another important issue, which is that these gaps are very common across the world. And so this slide shows access to universal newborn hearing screening worldwide, and shows that in contrast to the green countries, which are generally high income countries where 85 to 100% of children or newborns have access to universal newborn hearing screening. Much lower proportions have access in middle income countries. And in most places in sub-Saharan Africa, for example, the access of newborn hearing screening is virtually non-existent. And, there are a lot of reasons for these gaps. And I'll talk about just a few of them. So for one thing, the cost of the equipment is high. Um, in order to conduct hearing screening, one needs adequate trained personnel, and hearing screening is a thing that requires relatively quiet clinic spaces. And many health facilities in resource limited settings don't necessarily have those dedicated quiet spaces. There is a need for ability to engage with families to ensure that they have ability to seek out and are supported in their journey in seeking both diagnostic evaluation and follow-up care. And there's also a need to conduct screening in settings where there is available follow-up care, as well as access to hearing technology, such as hearing aids. And so some of those aspects of follow-up care that are really critical include pediatric audiology, auditory verbal therapy, which is a special kind of therapy that is really important for helping children with deafness or who are hard of hearing learn to listen and talk, as well as early childhood development support. And so the upshot of all of this is that these types of services and resources are really only available in private facilities or through sporadic philanthropy right now in Kenya. On the other hand, Kenya is a place where policymakers and experts are really, I would say, at the forefront of developing strategies to help address these gaps. And so the Technical Working Group on Ear and Hearing Care in Kenya is incredibly vibrant. Recently developed a national strategy for ear and hearing care for 2023 to 2028. And you can see a picture from the launch of the strategy, and you see a picture of my co-presenter, Sarah Degwa here. And what this national strategy really lays out is a lot of detail and some important policies to address some of the gaps that I've highlighted. So things like recommending coverage of hearing aids and cochlear implants through universal health coverage, and including otologic medications in the essential drug list, as well as county level sponsorship of ear and hearing care clinicians, including otolaryngologists, audiologists, and speech and language pathologists. And so one of the things that the research that we've been interested in is really looking carefully at the equipment availability and the cost of that equipment, and is there something that can be done to address this? Before I talk more about that, I will tell you a little bit about how hearing screening works. So in many places in the world, devices that can detect what are known as otoacoustic emissions, or OAEs, are used to screen for hearing. Otoacoustic emissions are basically sounds that are generated by the outer hair cells in the inner ear of the cochlea, and they make those sounds in response to sound stimuli. And so the otoacoustic emissions device basically takes advantage of the fact that these outer hair cells make sounds themselves in response to sound. And to detect those emissions, a probe is placed in the ear, and soft sounds are played at 4 different frequencies. And if the device detects otoacoustic emissions, this would indicate normal hearing or cochlear function, and would be shown as a pass on this device. However, if the OAEs are not present, the device will show a refer result. And OAEs are very challenging to detect in noisy places, because the sounds, the otoacoustic emissions themselves are quite soft. They are also challenging to detect if a baby is moving too much and if middle ear fluid is present. Now, these devices can be used by non-specialists, and it's important to note that they do carry a cost. So they cost about $4,000 to $6,000 US each. So is it possible to expand the use of these devices? At the University of Washington, at the University of Washington, where I'm based, I have linked with a couple of different researchers, computer scientists, who have developed some really interesting and innovative low-cost tools that can basically do the work of the device that I showed on the prior slide. And this slide shows a picture of one of these tools here. So this is a smartphone-based OAE device. It is basically coupled with an off-the-shelf microphone and off-the-shelf earphones. And theoretically, it has a material cost of US $10. And this was developed a few years ago. Again, the computer scientist Shyam Golakota was the lead here, and I'm showing you a picture also of his mentee, Justin Chan, who is now at Carnegie Mellon University. And this device has now been used successfully in 2 different studies of its test characteristics. And in both studies was demonstrated to have high screening accuracy. And both studies were done at Seattle Children's Hospital. And I'm showing you data on this slide for one of the research studies. This is a study that involved 76 infants. Their average age was just a little over 3 months. And important to note that this is a special population of children with a prevalence of 13% hearing loss. So the hearing status of these infants was known, and this slide just basically shows a comparison between the conventional results, the results for the conventional otoacoustic emissions device on the right, and the results for the phone-based otoacoustic emissions device on the left, in comparison to what was already known about these infants' ears hearing. And what we can see is that both devices had very high sensitivity and actually quite high specificity for detecting cochlear function in these infants. So a very promising research study, but important to note that both studies of this device were conducted in a high resource setting. So were conducted in a place where the ambient noise was fairly low. And just a side note, I want to highlight the fact that these researchers, Sham Golakota and Justin Chan, also at the same time have developed another smartphone-based tool, which is also really exciting. It detects middle ear fluid, and we'll refer to that in this talk as the smartphone acoustic reflectometer. It basically plays sounds into the ear and then detects the frequencies at which those sounds are reflected back into the speaker of the phone. And based on what it detects, it can detect the presence of middle ear fluid. So we're really interested in understanding the reliability and the feasibility of the use of both of these devices in settings where resources are much more limited and where there might be a lot of noise, and where, in particular, task shifting is an important thing to evaluate. And we successfully applied for funding to support a study of reliability of these smartphone tools. And I'm showing you on this slide pictures of our wonderful study team. And the study is called mHealth OAE Towards Universal Newborn Hearing Screening. And really the goal of this study is to try to not only understand the level of reliability for the use of these low-cost tools, but also help set the stage and evaluate various aspects of universal newborn hearing screening in Kenya. So aims 1, 2, and 3 of the first phase of this study were really geared towards understanding reliability and feasibility of task shifting. And so aim 1 is really developed around trying to understand if this smartphone device could be used in different noise environments. And in order to do this, we recruited and enrolled 30 different infants and examined it used the smartphone OAE devices to understand their hearing. And we did this in both a well baby nursery as well as well child clinics. For aim 2, we aim to identify feasible users of the smartphone OAE device. And so here we were interested in using or in comparing the use of the device by a specialist or an audiologist versus a non-specialist. And for this aim, we were really interested in understanding whether or not if we deploy the devices in the hands of both nurses and community health promoters, if the devices would function similarly as if we had given them to an audiologist. And then last, we wanted to understand what the user experience of these devices would be. So we wanted to understand the ease of training, the use and the durability experience of the devices. And in order to do that, we have trained 25 new providers of the devices and asked them to each test 5 different infants. So today I'm going to share with you results from AIMS 1 and 2. And you can see on this slide, for AIM 1, we thought pretty carefully about where we might cite this study. You can see a picture here of our team conducting a visit to Kenyatta National Hospital, as well as practicing hearing screening in 2 other health facilities in Nairobi. We ultimately decided to cite the study at both the the postnatal ward of Kenyatta National Hospital, as well as its well child clinic. And we also chose to base the study at the Mathare North Health Center in its well child clinic. And you can see here our study team in this photo is basically delivering an introduction to the study to health facility staff. Now, the next couple slides will give you a sense of the agreement between the smartphone and the conventional devices in these different conditions. This slide focuses just on AIM-1, and what we're showing you is different bars that show agreement between the smartphone and the conventional devices in 3 different places: in the Kenyatta National Hospital postnatal ward, and in well child clinics at KNH, as well as at Mathare North. And what you can see is agreement for 3 different age groups of infants: very young age in the dark blue, and age 2 weeks to 16 weeks in the medium blue color, and then an older group of infants in the green color. And hopefully what you can appreciate is that we had quite high agreement between the conventional and the smartphone at these 3 different sites, and across infant ages, suggesting that we achieved fairly good reliability of the smartphone in this phase of the study. And in AIM-2, what we really wanted to do was understand if we could, and it's important to note that in AIM-1, we had basically asked 1 audiologist to complete all of these tests. In AIM-2, we asked the audiologist to complete the tests side by side with a non-specialist. And so AIM-2 focuses on 1 single nurse and 1 single community health promoter testing ears of the same infant side by side with an audiologist. And so in all of these comparisons, everybody is using the same device, which is a smartphone. And what you can see is that our specialist versus non-specialist agreement is just about 80%. And this was true, again, across different ages of infants, from very, very young to an older age between 6 to 9 months. And so this data we find quite promising overall. And as I said, I won't share data for our 3rd AIM. We're still in the process of analyzing this data, but we recently completed data collection for this phase, and we're excited to dig into that analysis. And before I end, I will just highlight the fact that so our future directions here are to apply for continued funding for this grant. So the study that I just talked about was a 2-year study, and what we'd like to do is extend it to a 3-year study. And in this 3-year phase, we will hopefully have a chance to evaluate the smartphone based OAE within the context of a universal newborn hearing screening program. And so we'll look at things like reach of the program or penetration, as well as feasibility and acceptability within that context. And a third aim of that extended project would really focus on that tool that I mentioned earlier, this acoustic reflectometer that detects middle ear fluid. And our goal here is twofold. One is because this tool can be used to detect middle ear fluid, which is one reason why a child might refer on their otoacoustic emissions-based screen. We wonder whether or not putting these two devices together, combined into a toolkit, may be helpful to providers in streamlining referral for follow-up care. And the second question that we'd like to understand is whether or not this device can be helpful in understanding rates of otitis media with effusion, which is an important risk factor for hearing loss. And so before I end, I'll just highlight a few conclusions. Hopefully, one take-home message that you'll come away with is that it's critical to understand and address gaps in screening and diagnostic evaluation and follow-up of children with hearing loss, and that there are some smartphone tools that are promising for low resource hearing screening, and we're excited to continue to evaluate them. Some of the challenges may include noise in these clinics, and our next steps are to evaluate these tools in a universal newborn hearing screening program. Before I end, I would just like to acknowledge several people, many of which are directly on our mHealth OAE project, but some of whom are also involved in other projects that I didn't have a chance to talk about that involve hearing screening in general. And I would also especially like to thank, with a lot of gratitude, the wonderful staff at both Kenyatta National Hospital and also at Mathare North, and being especially welcoming of our study team and just being a wonderful group to work with. And I'd like to thank the study participants who generously offered their time in participating in our studies, as well as to the NIH and the University of Washington for support and research funding for this work. With that, I think I will hand it off to Sarah Degwa.
Thank you so much, Dr. Benki, for that wonderful presentation and for the results that you shared with us. We hope to hear about the results of the third aim, hopefully soon. And we hope to see what results that you'll get. So I'd like to make an introduction to our next presenter. Her name is Dr. Sarah Ndegwa. She's an audiologist, an ENT specialist at the University of Nairobi, and a research consultant on multiple studies in Kenya related to hearing and deafness, including the impact of HIV exposure on hearing outcomes. She's a fierce advocate for every infant in Kenya to receive hearing screening, as the impact of hearing loss can be detrimental to development, especially when discovered late in childhood. Welcome so much. Karibu sana, Dr. Ndegwa. You can go ahead and present. Thank you so much.
Thank you very much, Dr. Kagia, and thank you for the opportunity to make this presentation on family engagement, the ways forward in hearing. I'll just begin with an overview of the burden of hearing loss, which has also been mentioned by Sarah Benki. So we see that the burden of hearing loss is on the rise, or hearing loss is on the rise, with hearing impairment accounting for a major disease burden worldwide. Hearing loss is often referred to as a hidden disability by the virtue that it cannot be easily noticed. And so by the time it is detected, it has taken a long while. WHO currently estimates that over 430 million people globally have or live with disabling hearing loss, which is approximately 5.5% of the world's population. Of note is that 80% of these persons live in low and middle income countries. It's been estimated that by 2050, 1 out of 14 people will require hearing rehabilitation. So the graphs that you see here indicate the global trend in the hearing from 1985 to by the time it will get to 2040, we'll have 2.2 billion people with hearing disability. And then in the African region, it's also on the rise, and it's estimated that by 2030, we'll have 54 million persons with disabling hearing loss, and by 2050, 97 million people. So it is clear that we need to take action now. So today I'm going to be talking to us about a very important part of the management of hearing loss, which is family engagement, ways forward in hearing. So of importance is the topics that we're going to talk about of importance is education and awareness, learning about hearing health, hearing loss, and communication strategies helps families to understand and to support each other effectively. So the areas that we educate them on and create awareness around is the impact of unaddressed hearing loss. Then we also want to focus on early detection and intervention of the hearing loss, why, when, and how we go about that. And then we want to talk to them or engage them in family support groups and advocacy. So we'll talk about each one of them. So in terms of the impact of unaddressed hearing loss, we see, and one of the commonest with children is delayed speech and language development. So in the slides that were represented by Sarabanki, we noted that in the study that showed that the average age at which diagnosis is made is around 5 years. So usually from the age of 3, the parents will begin to come because of delayed speech and language development. There is also the challenge of listening and communication. Hearing loss will impact on the educational potential of the children. Later on in life, it affects their possibilities of getting good employment and their financial well-being. It's also associated with social isolation and feelings of loneliness accompanied by low self-esteem, challenges with interpersonal relationships just because one is not being able to hear the other, so there is a problem of communication. There's also cognitive developmental delay due to language deprivation and challenges with identity and stigma associated with hearing loss. And in the older persons, it's been associated with dementia. There's also an economic impact of unaddressed hearing loss. As per the World Report on Hearing, says that globally, the cost of unaddressed hearing loss is US dollars 980 billion, and regionally it is 27 billion US dollars. And this is really in the area, for example, of in educational costs, where you require lots of support, where interventions have not been made. And so here addressing hearing loss is very important. So when we are talking to families at every stage, we need to involve them in what the management of their child. And so we have a program called Early Hearing Detection and Intervention for Hearing Loss, and it has various components. So we'll begin by talking about universal newborn hearing screening. And one of the things that is important is that a child should have hearing screening, a newborn, at least within 1 month of age, according to the Joint Commission on Hearing recommendations. But importantly, it's also important to note that even though a child may pass the initial screen, along the life of that child, they might get an infection or take certain ototoxic medication and develop hearing loss. So there is also one needs to think about ongoing screening for babies at risk of hearing loss. Also children who get now other conditions that are associated with hearing loss. That's important to do ongoing screening. So it's not just that the 1 month after birth, but even ongoing is important. And for those who will refer means they did not pass the test for the screen. They required to go for onward diagnostic assessment within 3 months. And at that point, depending on the outcome of the diagnostic assessment, if it is a hearing loss, we need to determine what type of hearing loss. Some of the loss, for example, if it was due to fluid in the ear, otitis media, they may require medical management, and so appropriate referral is done. If it's a different type of hearing loss, that is the sensorineural type, that's where now rehabilitation with the assistive hearing technologies that we're going to be discussing come in. So diagnostic assessment becomes the next step. Then so we talked about the assistive hearing technologies. We'll be talking in detail about hearing aids, cochlear implants, and FM systems. And alongside with that, speech therapy is required to help speed up the lost time for this child and to help them to catch up. Another important component of early EDH programs is parental participation and family engagement. This is very key because the more you engage the parents and the family generally, the better you will get the outcomes and compliance. So it goes also along with adjunctive counseling at every stage, from the screening to the diagnostic to the intervention. You need to keep doing a counseling, and we will see some of the important things that we need to draw out for them. Then the other component of this program is social, psychological, informational support for families of children diagnosed with permanent hearing loss. And this is usually what we're talking about, sensorineural hearing loss. So hearing screening, when should it be done? WHO recommends across the life course. That means newborn, children who are preschoolers or school-going age. And then we have adults who are exposed to noisy occupations, and also just extracurricular activities that expose them to high noise levels. And then because of aging process, the older adults also require hearing screening. We have heard earlier about the recommendations by WHO and the Joint Commission of Infant Hearing Screening, which recommends that screening for hearing loss should be done by 1 month of age. The best time to do this one is upon discharge from the hospital after birth, but it can also be done at a post-clinic within 2 weeks after discharge from hospital. And then for those who refer, they go for onward diagnosis, which should be done by 3 months of age, and intervention should be done by 6 months of age. So this is just to show us the smartphone OAE that we've been using in our study. And all of this needs to be explained to the parents. The results of what you get, you need to explain to them what a pass means, what a refer means, so that they are able to comply with the next phase of the journey, especially if there is a refer. But even if there is a pass, it's important to really explain to them that the child may get unwell along the way. And if they notice that the child probably who was a little bit older was turning towards sounds is no longer doing so, then they certainly need to go for another hearing assessment. So then we come to the next phase. For those who will refer from the screen, we will do a diagnosis, and we have several tests that we do We have objective tests usually, but also for older children from the age of 7 months, we also incorporate both objective and subjective tests. So we describe the test procedure to the parent. Some children, especially even when you are doing, should have mentioned this, when you're doing the hearing screening, they are concerned as to whether the probe that you're putting in the ear is going to hurt the baby. So you need to cover that and tell them that it's a very quick test, it's not invasive, or rather it's not going to cause any pain to the child. Those are important things to tell them. And the same happens with when you're doing the diagnostic assessment. The diagnostic assessment is a bit longer than the screening assessment. The OAE test, for example, just takes a few minutes, can even take about a minute or less. But when you're doing now the diagnostic procedure, one of which is called auditory brainstem response audiometry, or ABR, it takes a little bit longer. We want a baby who is asleep, and sometimes we sedate them. So you explain the test procedure to allay any anxiety on the part of the parent. And then once the test is done, well, it is important to discuss with them the test results. You're telling them the type of hearing, the degree of hearing loss. Is it a mild, moderate, severe, or profound hearing loss? You invite them to ask any questions, or if they require any clarifications, you do the same. Many of them will want to know what is the cause of hearing loss. So where they have given you the history, you may work along that. Sometimes it's a genetic cause that you may not know about. So that can also be relayed to the parent. But if it's something that from the history, you can say that this is likely because of ototoxicity or hyperbilirubinemia, then you can sort of discuss that with them. Or they could also tell you there is a family history of deafness. So you can link that. It is important for them to also know that what is a likely cause. And this one is also important because traditionally, or I don't know whether to say culturally, they might associate the hearing loss with some, it could be like a curse or those kind of things. And so it's good when you are able, where possible, to tell them the likely cause. And then the next thing, to discuss the type of hearing loss. And we go into detail of this. It's really, again, important to tell them the types of hearing loss. We have what you call conductive hearing losses. And these ones are, for example, one of otitis media with effusion. That one is usually managed medically, or sometimes a surgical procedure. But you also have the permanent one, the sensory neural hearing loss, which now requires assistive hearing technologies, hearing aids, cochlear implants, and so forth. So it's important to discuss the type of hearing loss. While discussing the type of hearing loss, it's good to also show them this, what you call the audiogram. The audiogram is a reflection of how we hear. So where you have on the vertical scale and vertical scale, you have the hearing level, which is measured in decibels, and then you have the frequencies bar, which is on the horizontal scale. So you'll show them that if, for example, the hearing is at that level there of 30, you're telling them that your child has a mild hearing loss. If, on the other hand, it is around 90, so you're telling them your child has a severe to profound hearing loss, that you help them to understand that. And this is known as the speech banana. This is for low frequencies, we get to hear the vowel sounds, and for the high frequencies, we hear the consonants. Some people have an interesting pattern where you find they're hearing well in the low frequency, but in the high frequencies, they're all the way down to profound loss. So the mother will tell you, if it's like an older child who has delayed speech around 3 years, and said, but I don't think my child has a problem, because when I call them, they answer. But the child has still not developed language adequately. And that could be simply because maybe in the low frequencies where you have the vowel sounds, they are hearing okay, or relatively okay. say, for example, they're even hearing at 20, but then it dips all the way to 90 in the high frequency. So they're only getting parts of the speech. This is very important if you want compliance from the caregivers, the parents. This is one of the things that one needs to explain to them. What is the child getting access to? Which sounds is the child getting access to is important for them, because so that they can see that there is actually a problem. Also, when we're doing the next thing, we'll be doing counseling, and counseling, because sometimes when you give this diagnosis, especially when you're telling them it's severe to profound, they break down and they begin to cry, and the usual the stages of grief is, some of them will be shock, others will be in denial, and then before they come to finally to acceptance, and in between there'll be depression, some might get depressed. So this is a stage. The diagnosis stage is a stage where one has to really take time with your patient, move at their pace, because you may just lose that patient. If you may lose the patient, so you need to be very conscious of the patient and how they're responding to the news. Some of them had no idea, had no suspicion that the child had a likelihood of hearing loss. So when you tell them, it comes to them as a big shock. Others have been suspecting it for a while and probably even done some few tests. And I'm talking about those who have severe to profound loss. They may have said, this child doesn't turn. The mothers may have picked that when you drop something very loud, this child doesn't even turn. So they are somewhat prepared, or expecting this, but others, it's a shock. So depending on the way the parents present, you may need to involve a counseling psychologist to help them to go through that grieving process and come to a place of acceptance. The most difficult thing about this is that time is of the essence. We can't afford for us to lose too much time while the parents are, going through the stage of grief. So this has to be handled very well, and sometimes it would be good also to involve a counseling psychologist. So following which, then you may not discuss the entire management plan in this first stage of diagnosis, because as we said, it comes for some of them as a great shock. They're in denial, they can't accept it, they don't believe your results, they want another test, they want a second opinion, and so forth. So that happens. So it is sometimes difficult to move to the discussing with them the management plan. Unless, of course, it can include something like referral to the ENT for medical management if you have done other tests, because we do a battery of tests. It's not just a hearing test. We also do middle ear tests. So you may have done that and realize that this is actually again, I give the example of OME, then you refer to the ENT for medical management, following which they come back again for a repeat test to see whether the hearing has come back to normal. But in cases where you have the permanent hearing loss and you'll require rehabilitation, you may not achieve everything in one sitting as to discuss the management plan, but you will then give a follow-up appointment for them to come and have that discussion. Remember, the more the patient or your parents understand, the caregivers understand, the more they're going to be compliant with the entire journey. So in terms of the intervention, when now they're ready for this discussion, depending on the degree of hearing loss, up until from mild hearing loss, sensorineural hearing loss, all the way to something like moderately severe, hearing aids can work very well with that. But where it is now moderately severe, going to severe to profound with no benefit from hearing aids, then cochlear implants are then the best option for that. So here we see, and this one we see, this is a hearing aid, a behind the ear hearing aid. It's called actually a receiver in the canal hearing aid. This one is called a bone conduction hearing aid. You may find like this patient has stenosis or atresia. Then this is a cochlear implant where you have the external processor The cochlear implants has two parts. There's the internal part and the external part. The internal part is the electrode array that now takes over the role of the inner hair cells. And then you have the external processor, which is the one that picks up the acoustic signal and converts it into a digital digital code that is relayed down the electrode array, then to the auditory nerve and to the brain or the auditory cortex. So at this stage is where now you will discuss with the parents what is the degree of hearing loss, what are your options based on the hearing loss. Is it going to be hearing aids? Is it going to be a bone conduction hearing aid, or is it going to be a cochlear implant? Then we have what you call FM systems. These ones are very good for classroom settings, generally classes. Classroom setting is very large, and so noise is one of the biggest challenges for people who have hearing loss, even when you have a hearing instrument or a hearing device. So to add on to that, you can use what you call FM systems, where the teacher wears the transmitter, and this one is wirelessly transmitted. The teacher's speech or the signal is wirelessly transmitted to either the hearing aid or the cochlear implant the child has. This is in a classroom setting. And so the FM system helps to overcome issues to do with background noise, as well as distance from the speaker, in this case, the teacher, and also helps to remove issues to do with echo, eventually giving that child a very good listening environment, and they are able to catch up much faster. The other discussion you're going to have in the management plan is the type of device. We've talked about that. Then cost is also important. Care and maintenance of the device, and simple troubleshooting of the device. Now, the issue of care and maintenance is very important because we tell parents that every time the child is awake, they must have their hearing device on because they need to hear all the time. And so then care and maintenance of it is very important. Make sure that they have batteries. And for those who have rechargeable batteries, if the device is using rechargeable batteries, then or it's a rechargeable hearing device by itself, then that needs to be charged, and the child wearing it all the time, except, of course, all waking hours, except when they're asleep. Then you need to discuss the aspect of speech and language therapy. This is important, more so in our setup where diagnosis is made late. And so there is a lot to catch up on to cover that, the hearing gap. So speech therapy is very important, where they learn how to speak, listen and speak. And increasingly, we are advocating for home therapy, because usually when speech therapy is done, it's probably once or twice a week. But the rest of the week, the child is at home. And so speech therapy, home therapy is very important. Speech therapy at home is very important. And many parents parents are working. So the other very important person to be part of this rehabilitation is the nanny who's at home. And so for all the speech therapy appointments, the nanny, it's important, the nanny who's with the child needs to be there, unless it's a stay-at-home mom. If the mom goes to work, then the nanny needs to join the speech therapy sessions so that they understand what they can be doing at home, because the child has to be exposed to conversation, to sound, like throughout. So the nanny needs to also understand why that is important, and not just leave the child playing by themselves or behind a screen, television, and so forth. The other thing we discuss with the parents is about school placement, appropriate school for the child. If you have these interventions that we've talked about, these technologies, these children can be mainstreamed. But even as they are mainstreamed, we still give them advantage of sitting position, sitting in front, And, if there is possibility of having reducing background noise, this mainly is to do with the hearing aid itself, or the cochlear implant processor has some technology that can sort of cancel out noise. But there are also other strategies that schools can do, for example, boards and carpets that absorb sound. Now, some of these are not very practical, but they're still something that parents can advocate for. Once they understand why, they can also advocate for the same. And then the one that we talked about that gives a child an immense advantage in terms of getting the signal well from the teacher is the FM system that is linked to the hearing aid or to the cochlear implant. I think we shared this slide earlier on. Again, this is also very important to explain to the parents why early intervention is important because of just the human brain development. Sarah Bank talked about the neuroplasticity, which is the brain's ability to adapt and recognize its neural pathways and functions in response to a stimulus, in this case, an auditory input. So neuroplasticity is greatest in the first 3 years of life. And as we see here, it peaks within just the first year. And so early intervention will take advantage of this neuroplasticity so that we are able to stimulate and develop the brain within this critical time period. And so when we go back again to the process of grief, when they get the diagnosis about the child not hearing, we need to handle it very carefully and explain to them this very carefully, because they may go away and then come back. The child was 3 years, they come back when the child is 4 years. So you've lost an entire year. So they need to really understand this process quite well. Also, we try to explain it to them in the simplest way possible, so that they go out not too much of jargon, so that they really just understand what you have said, and invite them for another appointment where you can revisit the same discussion so that they really understand. And even as they are going through the grieving process, that period can be shortened. So when we're doing the counseling and engaging the family, we have a family-centered care approach. You create a welcoming environment. This is really just in even how you lay out your sitting arrangement. The family members sit around a table, and then it kind of makes them feel included. And so you have that discussion there. At one point, you may also want to include siblings. Siblings are often forgotten, and at a certain stage, especially when you begin now the intervention, it's important to include the siblings, because some of them are almost the age of the child and they'll keep having conversation. This child just needs to hear people talking. They have lost some period of time of not hearing, and so we need to give them a lot of auditory input, and siblings come in very useful with that process, as well as also helping the young child, to take care of their hearing aid or speech processor for cochlear implant. So create a very welcoming environment, establish open communications, create an environment where family members, they feel comfortable to discuss their feelings and concerns that are related to hearing loss. Professionals should actually be very actively involve family members in the decision making. You guide them and allow them to make the decisions, recognizing them as the key partners in the child's development. Then we encourage parents to have or to join family support groups and programs. So connecting families with others facing similar challenges fosters a very supportive community. And of note here is that when we talk of the family, we are bringing in everybody who's maybe even living with that child or in that child's space, father, mother, siblings. That is really the family. So, and the nanny also should not be forgotten in this process. So bringing them together in support groups is very good. They're able to share their experiences and advise each other, because each one of them might be at a different stage of the hearing journey. So this advice strengthens them and their likelihood also to be able to heal through the process of after having been told the diagnosis and now the intervention. So when some parents talk to the other ones, they get courage, they're able to overcome that. So we really encourage that, as well as the mentorship programs, which is pairing new families with the experienced ones to help to provide guidance and reduce the feelings of isolation. So the other engagement that we encourage parents is advocacy and lobbying. Parent advocacy for children with hearing impairments involves parents actively working to ensure their children receive the appropriate support and services, especially in the area of education. They can request for individualized education programs in schools and seek also specialized therapy sessions in school, such as auditory verbal therapy. And this one would also works very well if there are more than one child in a school with a hearing challenge. But even if it is just one child in that school or class, the parents can advocate for an individualized program on auditory verbal therapy. Families can also advocate for inclusive practices in schools and communities that facilitate for better social integration for the children with hearing loss. In the healthcare space, the parents can advocate for newborn school hearing screening. They can advocate and lobby for this, as well as assistive hearing technologies, access, affordability, and availability. This is also where we let them know that the disability council, but they also offer, once you register with them, they can support in the costs for hearing aids. So long-term advocacy and cochlear implants. Long-term advocacy involves engaging families. Engaged families are more likely to advocate for their child's needs, ensuring continued support and resources. So what are the benefits of family engagement? One is enhanced language development. Active family participation accelerates language acquisition and communication skills. Also, they get emotional support, and nurturing family environment helps children develop self-confidence and emotional resilience. Families can advocate for inclusive practices in schools and communities, like we mentioned, facilitating better social integration for children with hearing loss, so that these children are not, when others are playing, then they are by themselves. So families can advocate for some of the activities that the children with hearing impairment can be engaged in. Engaged families are more likely to advocate for the child's needs, ensuring continued support and resources. So in summary, in family engagement, we need to provide families with education and awareness on hearing health, hearing loss, and communication strategies. One simple communication strategy is which is used in auditory verbal therapy is just talk, 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 talk. The child needs a lot of auditory input. This helps families to understand and support each other more effectively once they're educated on the hearing loss and hearing impairment, and you create that awareness, as well as also the culturally thinking that this problem is a different kind of problem that is, like we said, for example, it's a curse. So that keeps them away from the help that they would get when they move towards that thinking. So educating them is very important. Encourage families to join family support groups. This helps to for that emotional support, psychological support. Then advocacy and lobbying for hearing. And this can also be at using, for example, legislators as well. The lobbying can be through legislators, so that when they are writing down policies, the issues of children with hearing impairment and others who are persons with hearing impairment are considered. It's important also to always think of this management and family engagement by engaging a multidisciplinary team, which includes audiologists, ENTs, specialists, speech and language pathologists. We need a clinical psychologist, a pediatric neurodevelopmental physician, and nurses. As you know, even in the studies that we've been doing, we've been working with the nurses to do the hearing screening. Educators, the teachers in schools are very important. They're with the child most of their waking hours during the day. And then also social workers, because sometimes there are issues in families which might be related to the hearing loss or not, which might affect the outcomes for the child who has hearing loss. Thank you very much. These are the people in our study. And the acknowledgements to our mentors, collaborators. Thank you, everybody. Thank you very much.
Thank you so much. Thank you so much, Dr. Ndegwa, for a wonderful presentation. Maybe one question that I've seen that is going on is how accessible, and maybe can you talk about the costs of the cochlear implants and maybe the hearing aids within Kenyan spaces, and you working here at Kenyatta National Hospital compared to other referral centers, especially within other counties. So how affordable and accessible are the cochlear implants and also the hearing aids? Thank you.
Okay, for the hearing aids through the national strategy, we were able to work together with supply. Anyway, they are in the package for hearing aids is available, and it covers up to 50,000. So in average, one hearing aid is 50,000 shillings. But as we said earlier on, also, as we talk about costs, also remember that the initial cost might be seem a lot, and it is. But when you look at lifelong cost, it is more expensive to do nothing. So that's the cost of hearing aids. So if you're talking about a pair of hearing aids, that would go for 100,000 roundabout. Then if for cochlear implants, in country, we normally just implant 1 year, not because we can't do bilateral, but because of the costs. So the cost of a cochlear implant, we provide it as a package, which includes the admission, which is usually just around 3 nights, the implant itself, the surgery, and 1 year of rehabilitation. That 1 year is very critical because many of our children who are implanted at the age of 3. So once we do now the implantation, their hearing age is just 1. So we have to close that hearing gap. The younger the diagnosis is made and intervention is done, then you're able to close that hearing gap very quickly. So for our program, we insist as a part of the package to have that 1 year so that they come for the programming of the processor for the cochlear implant, which we call mapping, as well as they attend speech therapy sessions at least once weekly for an entire year. So we offer that as a package. And that said, it's the total cost is 3.5 million for one side. One side if done early enough, the child will develop speech and language very well. I think I've answered your question. So, yes, the other question was what's available at, did you mention Kenyatta?
I meant since you're working within Kenyatta, are these services available within other counties and areas within the country?
Okay, so the Ministry of Health, in collaboration with the Clinton Health Initiative, have been able to give or are planning to give diagnostic equipment to various counties. I think it's probably around 7 counties. Kenyatta has received a diagnostic not a screening ABR, which is already in use at the hospital. So in terms of a complete range or comprehensive care, audiological care is being provided at Kenyatta. We have screening, ongoing screening. We have diagnostics that are being done there, and we also have hearing aids. And maybe I would say that from time to time, we get donors who come and provide us with hearing aids. And so please refer some of the children whom are young, especially the ones who are younger than the age of 3. We have not been able to get them, maybe because we don't have very robust hearing screening programs. We do have hearing aids that are at the hospital from time to time. And this is one such time that we have hearing aids available. There is a cost to it, the cost for logistics, which comes to about 10,000. So the hearing aid itself, we don't charge, but the services are charged, comes to about 12,000 or 10 to 12,000 shillings. So kindly refer those young children there, first of all, for screening, and then also for the diagnostics. And then while we are still trying to establish universal newborn hearing screening for all the children who have risk factors for hearing loss, prematurity, low birth weight, they definitely must be done hearing screening. And then for those who refer, go for onward diagnostics, and intervention is available.
Sarah, I wonder if you could also please speak to the situation of a child who has not had access to assistive technology or cochlear implants, and they're deaf or hard of hearing, and they're older. And also, perhaps you can speak to children who might have a complicated clinical situation, which is hearing loss paired with autism spectrum disorder or another condition.
Okay. So let me begin with the one that is paired, let's say autism plus hearing loss. So we've noted that for those kind of children, you need a multidisciplinary approach where you refer them to the neurodevelopmental physician or pediatrician. They may require occupational therapy. But in intervening, we are seeing many of the children sort of calm down. Their hyperactivity, is much less. So we will go ahead and intervene for those ones. Usually for those children, they'll come with delayed speech and language. And so for any child who has a delay in speech and language, whether it's associated with ADHD or autism, hearing assessment must be done. And should we find that they have a hearing loss, then we go ahead and intervene. Intervention can be done. Now, for the older children, children who are now, let's say you had congenital hearing loss and is the age 5, and has severe to profound hearing loss, cochlear implants can be done, but they'll be a very, very big challenge because you have lost 5 years of hearing. And because of neuroplasticity, it is that much more difficult for that child to catch up. So quite often we say over 5 years is really, 5 years is borderline. So for that child who cannot even access cochlear implants because of costs, then the next best option for them is a school for the deaf. And this school for the deaf, usually admission is from the age of around 6 years. So many of the schools for the deaf are boarding schools. So that's another whole discussion to have with parents, because you are releasing your 6-year-old child to go to a school for the deaf. So that one we require a lot of counseling and support. And also the parents, also we encourage those parents who have their children going through the system of school for the deaf, they also need to learn sign language, because when the child comes home, how are they going to communicate? So that is an option, and it is a very important option for this child, because they have to have a mode for communication and live their lives. Never mind that there might be limitations, and there are, but this child can still function. You know, at least they need a mode for communication, and sign language then becomes the next best option for this child.
Thank you so much.
Thank
I
you.
wonder if you could also speak to what providers can do to contribute. There's a very good question about contributing to early diagnosis and potential help to provide to clients, even when they're not necessarily an ear and hearing care specialist.
Yes. So the first thing is sometimes it's important, first of all, to even to listen to the parents, especially we are concerned about every level of hearing loss. But for those who have severe to profound, the parent will tell you, my child is not speaking, or there's a delay in their speech, or they've noticed something. Take them seriously and just go ahead and refer that child for an assessment. That one you must do. You can, of course, do some simple tests. There are certain simple tests that you can do, like, for example, a whisper test, and see whether the child turns towards you at the back. But in any event, that child requires to be done screening and diagnosis. So milestones are the things that can be very good pointers for you to see. Speech and hearing milestones are important. Like if you're looking at a child who is around 6 months, this child with the sound from behind them and they're not looking at the sound, they should be able to turn and localize towards that sound. By the time they're getting to 1 year, this child has got some of their first words, bye-bye, just one word, bye, or mama, and those kind of things. So those are the things really to look out for. For some of the older children who, not older, but preschoolers, age 3, 4, 5, who might have otitis media with effusion, for example, most times it is actually the teacher who points it out to the parents that this child sometimes seems to be hearing and sometimes doesn't seem to be hearing. So when that kind of a child is brought to your attention, then again, they need an ENT, and they will also need, there are certain tests we do, the hearing test, the middle ear function test, and of course now the ENT can look into the ear, and if there's a OME, they would be able to see that. So I think the thing to say is that concerns from parents is important, and just always send the child for the diagnosis, because time is of the essence for these children. Timely and appropriate intervention is a must for them in order to get good outcomes. So yeah, that would be important. And any child who comes within their speech developmental milestones are not appropriate must have a hearing assessment. And this includes a child who's 3 years and is not speaking, or just has a few words, is not joining sentence, 2 words together. There is clearly an issue, and so assessment has to be done.
Thank you, Sarah. There are a lot of questions about specific children that I hope you can take a look at. You may be able to provide these attendees with some ideas for resources.
Okay. So I see a question here on the treatment of tinnitus. Tinnitus, just in a nutshell, we really don't, we say treatment, we say management, but it's really management of tinnitus. And in this one, you need to start off, of course, with doing a very good hearing assessment, and then looking out for all the likely causes of the tinnitus. And then they go through tinnitus retraining therapy, just to help them to cope with the tinnitus, so that they get to a place where the tinnitus is not annoying or intrusive. To help manage the tinnitus, we also have hearing aids that have tinnitus maskers. In other words, they generate a sound that masks the tinnitus that they hear, and so it makes it more bearable, or one is able to habituate to the tinnitus and just cope. So the most difficult thing about tinnitus, it can be very annoying, it can be very intrusive, and so we try to manage it by first looking out for the cause. If we can find it, you treat the cause. If there is no specific cause, but they still have the tinnitus, then we do lots of counseling. Tinnitus also becomes worse. The more you think about it, the more you dwell about it, it has this vicious cycle. So we need to break the vicious cycle, and the way to break it is just going through some what we call tinnitus retraining therapy, which helps the person to habituate to the tinnitus. So in that way, we say we can manage the tinnitus. Let me see. Next question. I'd like to know to contribute to early diagnosis. What can I do to help? Okay, I think this was about the early diagnosis. Yes, so how to contribute to that is, well, ideally, this hearing screening, first of all, can be done newborn. It can also be done in well baby clinics. It can also be done in immunization clinics. So if where you're working, this is possible to have this equipment and the staff who can do it, that would be good. If not, then you'd probably have to refer to a place where that can be done. And of note, if from the history you pick up any risk factor that this child may have had, risk factors for hearing loss, children who are born prematurely, children who have maybe been in NICU for more than 5 days, those who have had ototoxic medication, some of those, or a family history of hearing loss, or a family where one child is profoundly deaf, the other children have to be assessed for hearing loss because it could be genetic as well. So you can assist by referring them and really encouraging them to have that test, but not only just to have the test, but the intervention thereof. Because again, some would have a diagnosis and then they just go back and just sit back until you have passed your critical time for intervention. So you would really help by, if you had referred them for diagnosis and you can get access back to them, tell them, so what intervention, what were you told? We see parents who bring in their children diagnosed at 3 months hearing loss, and then they come for intervention when the child is 6. So by that time we tell them, well, I don't have any other option right now. I only have one option. You've now brought down the options. And for that child now, sign language becomes now the best option for them in terms of communication. So counseling them is very important. Hearing loss is a hidden disability. You can't just see it obviously. So that's how I think you can help. And I think because it is hidden, sometimes when someone, a child in school, for example, keeps on saying, pardon, pardon, you can see there's likely to be a hearing loss. Hearing loss for India. So my friend's son was diagnosed with severe hearing loss on one ear and profound on the other. He recommended for cochlear implant, but could not afford. The boy is 10 years old and is also autistic. How can he be assisted? So now we talked about the critical age for intervention in terms of hearing, especially now we are here talking of severe and profound hearing loss. So this child, the one that you mentioned here, is 10 years old, has severe to profound hearing loss and is autistic. This child, one of the things is management of the autism has to be done now by your neurodevelopmental specialists, occupational therapists also. In terms of the hearing, this child, once again, the option is just sign language, but because they are autistic, that has to be managed well first so that they can be able to learn sign language. But the other thing we could do is for the ear that has got a severe hearing loss, I would give a hearing aid just for only one reason, to give that child sound awareness, but they will not be able to fully access hearing because of the severity of the hearing loss. So it is not a good idea for this child to go to India. So you should discourage them from going to India, not just even to India, even if it was being done in Kenya. And in case we don't do it at that age, a child who has congenital hearing loss at 10 years is really not good use of their resources. Actually, it's a waste of their resources. So I would just recommend a hearing aid, and that is only for sound awareness. They have passed the critical age for intervention in terms of cochlear implantation. Male patient. Okay, next question. A male patient is found out his right ear is not hearing. Sorry. It's not hearing when he was 8 years old. What could be possible causative factors? Okay, so this one, I think this is called single-sided deafness. There are very many causes of single-sided deafness, which includes from, it could have just been congenital. The person was already deaf on one ear, but only realized when they are 8 years old, because that's the time when they are probably looking for a phone and they realize, I don't hear anything from this ear. So it could be mainly viral infections as well, one of which can also be like mumps, can give you single-sided deafness. It could be trauma. Yeah, those are some of the causes that can cause hearing loss. Now, in terms of intervention, this one can benefit from what you call a cross-hearing aid. A cross-hearing aid is a hearing. Oh, the male patient, how old is the patient? How old is he now? That one, it would be important to know how old he is now, how long the deafness has been, because also that is very critical, how long the deafness has been. But for single-sided deafness, we have got several options. Depending on how long you've had the deafness, you can have a cross-hearing aid or you can have a cochlear implant. Where can someone get hearing aids at a fair price for someone with old age-related deafness? Which types are best easy to maintain around North Rift areas? So right now, there are very many places. The average cost, even in the market, is probably from around 60,000, 70,000 shillings for one side. So for two would be 140. But where costs are great, I think I would suggest that you can try Kenyatta. From time to time, we get hearing aids donated to us there. And I really want, especially for children who are below the age of 3, if you could kindly, or even 4, if you could kindly, those who are not able to afford elsewhere, that they could also visit the audiologist clinic at Kenyatta. Thanks for the support hearing children who cannot.
Thank you so much, Dr. Ndegwa and Dr.
Yes.
Benki. I am being informed about the interest of time. So we are kindly requesting if you could share resources on the chat box, or you can share resources with the KNH research team so that you can also be able to share with our participants.
Okay, I will share with the research team.
Yes, so that we can be able to share with our participants, because this has been a very interesting and very informative session. Thank you so much, our presenters, and we hope to invite you the next time so that you can inform us more about the ongoing research and maybe more advocacy on screening, especially for children below the ages of 3 years. So with that, I'd like to thank you so much, and I'd like to wrap up the session and wish everyone a good night and a good day, and welcoming everyone else to continue joining us from tomorrow till Friday for the remainder of the sessions. Thank you so much. Good night and have a nice day. Kwaherini.
Thank you very much, everyone. Thank you.
Thank you. Thank you, Dr. Sarah.
Thank you, Dr. Sarah Banki. Thank you, Dr. Kagia, and everybody else.